Good morning, good afternoon, good evening to all of you joining from around the world. Whether you're tuning from a bustling capital, a field office, or somewhere in between, we're very thrilled to have you here. Before we dive in, let's do a quick warm-up. In the chat, if you could drop one word that describes the current state of nutrition data in your context. Just one word. It could be complex, invisible, critical, transforming, whatever comes to mind. So great. Thank you. That already gives us a glimpse of the diversity, shared challenges and why this new guidance matters more than ever. My name is Hassan Ali. I am a nutrition specialist with UNICEF headquarters, and I'll be leading you through this webinar. We thank you again for being with us today, and we hope that you'll benefit from the discussions that will be happening here and the case studies and the practical examples that would be shared. Next slide, please. So we have a packed agenda. We have 1 hour to fulfill this agenda, but we hope that the diversity of the different sessions would be very informative and useful for your own experiences. And this is just the beginning of our engagement together. We hope to have more sort of consultations and feedback from your experiences in the field and learning from each other through this guidance and improving on how we make data available in the field. So our agenda today will cover 3 case studies, one from Gaza, one from Niger, and one from Myanmar. We'll also do a quick overview of the guidance that's been developed and is now available on the GNC website. But before we do all that, we'll have a few opening remarks from our Head of Humanitarian Action in Nutrition, Anuradha Narayan. Anu, over to you, please.
Thank you, Hassan. And again, greetings from my end as well to colleagues who have joined. Good to see a large number of you online. And I sincerely hope that this webinar will be of use to you. Even, as you all know, because you've all joined here, that the importance of data, particularly in crisis context, is becoming even more important than ever before. And as nutrition practitioners, we've always sort of benefited and enjoyed having high quality anthropometric data that is held up in great esteem and high standards. And we've always been able to use and inform any kind of global situation based on that. We also know that that data is so valued because anthropometry or child wasting data in particular reflects not only one dimension, but as an accumulation of multiple insults that have led to a child being in that status. And it's a reflection of poor health, services, diets, as per sort of the UNICEF's conceptual frameworks that you're all very familiar with, and hence has been something we have been able to really actively contribute in terms of any kind of sort of global assessment that does happen. But we also know that the circumstances are changing so rapidly, whether it's due to climate change or conflict or displacement, that we absolutely need to adapt to the current circumstances, which is also highly financially constrained. And I think more timely, more time sensitive, more reliable data and ways of both what we collect and how we collect really needs sort of a reassessment and a time for us to come together and learn from each other. So I'm really glad that the webinar is happening today. And these 3 case studies, I think, truly reflect the very changed circumstances under which we are now being expected to both gather information, interpret it, and also provide that so that both advocacy and action, including financing, can follow. And I'm sure you will have a lot of questions to learn from and ask each other And we hope that we can be not only looking at these tools, but adapting more of that. So for early predictive action, more digitalization as we go forward with things. So I'll start by also saying that don't also join us. The Global Nutrition Cluster has the NIS Technical Working Group. And I think we are always looking for people who are typically not, who may not yet have participated in these working groups and in these avenues to join us, because often you might have the best idea that we haven't yet tried out. So as you listen, I also welcome you to contribute and join us so that we can be better in terms of sort of giving voices to those families and children that we hope to serve. Back to you, Hassan. Thank you.
Thank you very much, Anu, and that gives us a very good start for this webinar, and thanks for those words. Next slide, please. So we have a variety of presenters with us today, and as I said earlier, a lot of this, the intention here is to really learn from each other. So we've tried to bring in field level experiences and case studies that are demonstrating the adaptations that countries are already doing in relation to, how do they make data available in contexts where access might be a constraint, resources may be a constraint, or both. And so we hope to have a really sort of good discussion and presentations that will also shed light on how different contexts are sort of making their own adaptation. So we have a panel of presenters today. As I said earlier, Gaza experience. We have Wande who will be presenting there. We have Justine who will share with us her experience on Niger and the work that they've been doing there. We have Emily, who's from ACF in Myanmar, who's also joined by 𝗂𝘂𝘁𝗂𝘂𝘁, who will also present their Myanmar experience, and many others that will have more time to discuss. Please note that the webinar has a sort of simultaneous interpretation in French, English, and Spanish. So please, you can access all the interpretation there if needing to have any translation. Next slide, please. So before we begin, I just want to highlight that we have with me Alexander, who is from ACF UK, who's the co-chair of the Nutrition Information Working Group, and she will also be a co-presenter with me in this webinar, and she will be facilitating the Q&A section. Alex, I don't know if you have your video on and you're with us, and just put it on for a second.
Somehow my video is not coming up today.
That's all right. Okay. We'll get to see it later.
For the Q&A, I'm perfectly fine without the video. I don't know why it's not going up, but yeah, I'll be there for the Q&A. Thank you. Thanks a lot, Hassan. We're really glad to present you those different experiences today. So hope you'll enjoy it.
So as many of you know, the demand for real-time actionable nutrition data is growing, particularly in contexts where traditional assessments are no longer feasible due to insecurity, funding constraints, or operational access issues. This guidance was developed in response to that need through collaboration between UNICEF, the Global Nutrition Information Working Group, and a range of technical experts and country partners. So this is really something that has had a lot of consensus built around how we put this together. And in today's webinar, we'll walk through the rationale behind the guidance, and most importantly, hear from colleagues on how these approaches are already being implemented in places like Gaza, Niger, and Myanmar. And we hope that you'll find these examples not only informative, but directly applicable to your own work. Next slide. So this guidance is designed to both be practical and flexible, recognizing that in many humanitarian settings, we cannot rely on large-scale surveys or routine systems alone. Its primary purpose is to help you maintain a functional and reliable nutrition information system, even when resources, time, and access are severely constrained. The guidance is aimed at those of you managing or supporting nutrition information systems, whether you're working in a government, the UN system, or local or international NGOs. The guidance is also including decision trees, real-world examples, technical annexes, and adaptation pathways. Ultimately, this is not just a technical document. It's a strategic enabler to ensure that we continue to protect children's lives and guide effective response even in the most difficult settings. Next slide, please. So what's new or different in this guidance? This guidance builds on existing tools and methods, but takes a major step forward in adapting them to unique challenges we face in today's humanitarian context. First, this isn't just a technical manual. It provides decision-making frameworks, guidance on how to adapt approaches depending on your context, and also addresses ethical considerations such as when and how it's appropriate to collect data in highly insecure or resource-limiting settings. Second, it's grounded in real-world experience. So we wanted to make sure that we are not providing any sort of information that is not applicable in the field context. So the guidance reflects lessons from countries that have innovated out of necessity, for example, using screening data collected during health campaigns or enabling communities to report milk measurements via SMS. Third, there is a strong emphasis on multi-sectoral data triangulation. That means combining nutrition indicators with food security, health, WASH, and social protection data to generate a more complete understanding of nutrition risk. Fourth, the guidance introduces new tools, such as the EC-FIES, the Early Childhood Food Insecurity Experience Scale for measuring childhood food insecurity, the Nutrition Vulnerability Analysis Method for estimating nutrition risk without surveys, and the Rapid Nutrition Determinant Assessment for rapid qualitative insights. Lastly, it provides tailored advice for remote data collection, addressing common risks like selection bias, poor data quality, lack of digital literacy. It also includes tips for sampling, training, and hybrid methods that mix paper-based and mobile approaches. Overall, this is a living document. It's designed to evolve as field conditions change and as more countries share their experiences implementing these adaptive strategies. Next slide, please. So there are 4 core strategies adapted as part of this nutrition data collection. So it lays out these 4 core strategies. The first is we use what data already exists, whether from routine monitoring, previous surveys, or even other sectors like food security and health. Second, we want to apply digital tools, DHIS2, Rapid Pro, 𝗂𝘂𝘁, and many others that are available to continue data collection remotely. And third, integrating new methodologies like the Early Childhood Food Insecurity Experience Scale, which is a perception-based tool for understanding childhood insecurity, or the nutrition vulnerability analysis, which triangulates routine data with expert judgment. And finally, it stresses the importance of joint analysis, bringing stakeholders together to interpret data contextually and transparently. Next slide, please. So now I'm going to invite our colleagues from Gaza to share the first case study, which is the Gaza experience. One day, if you're with us, over to you.
Yeah, hello everyone. I don't know if you can hear me, and I think you can see me. Unfortunately, one day is traveling right now between the office and the guest house in Gaza, so we won't be able to do what I will do for him. We can go directly to the next slide. So what we wanted to show for the Gaza experience is a situation where we started with almost no CMAM programs, situation that was that we thought will deteriorate quite quickly with previously a surveillance system, but that's collapsed with the war. And so trying to see what we could do with the different partners to be able to monitor the situation and to have the data to try to see what's happening and follow up on the situation. As you can see in this screen, we try to see how we could use the Murex screening that was used actually for the program and first and foremost to detect and to scale up actually the detection of the children to get additional and sufficient data and quality data to be able to see this situation. And we have seen, as you can see in this in the little graph on top, that we really were able to scale up the number of children screened within the Gaza strips throughout the year, reaching more than between 80,000 and 100,000 children by the end of 2024. And from these children, 1/3 to 50% were collected as individual data collection and sent from the different partners, to the nutrition clusters. And through this data, we were able, with the support of the SMART initiative, and I will show a little bit the key analysis that was done, but to do data quality analysis to ensure that we can use this Murex screening data to have something that could be closer to proxy GAM through this different analysis of the quality of the data, of the type of data, and try to figure out some elements. What has also been really important is that we used the bi-weekly and then the monthly cluster meeting to show this data, to give feedbacks to partners. We also worked really at the field level to give these feedbacks to the different partners to improve little by little the quality of the data and ensure that we had enough. By that, as at the beginning of the year, there has been the beginning of 2024 actually. There has been 𝗖𝗶𝘁 exercise on which it was not possible for nutrition to really give data because it was, of course, not possible to do any survey in the situation and during the war situation with a high displacement of population, difficulty to do the samplings, etc. But we had enough data to be able to incorporate in the 𝗖𝗶𝘁 analysis as soon as October 2024 and do it again in April 2025. So it's also helped us really to improve and to increase the visibility of the nutrition situation in Gaza for the different partners based on data that were the most reliable as possible and were recognized actually by the different partners as of sufficient quality to do this kind of analysis. We can go to the next slide. So the next 3 or 4 slides are really to try to show you what was done. So for each of the governorates, actually, we try to look at the different data sets that was sent by different partners, and you can see that really we had a lot of partners participating to this exercise. Looking at the date of the screening, the settings, to try to understand a little bit more where the screening were done, to understand whether it was within health center, outside of health centers, the sample sites, but also the differences between the children that were below 2 years and above 2 years, to be able to interpret it and weight actually the GAM Murex. So it was done really on a very systematic manner by the SMART initiative and presented to the cluster in the cluster meeting every month. We can go to the next slide. So this is really to try to show you what was done. So for each of the governorates, actually, we try to look at the different data sets that was sent by different partners, and you can see that really we had a lot of partners participating to this exercise. Looking at the date of the screening, the settings, to try to understand a little bit more where the screening were done, to The SMART initiative also did a lot of data quality analysis to try to see whether the data can be used or not, trying to really figure out what were the main problems, so we can also feedbacks to the different partners to understand the situation and try to give them some elements to improve also the quality of the data. Can go to the next slide. We also had a very strong focus on age heaping to try to really show that it was important to have the right age to avoid some bias. And we have seen really that by the time the data really improved actually throughout the year, and the age heaping was really less important by when time arrived, with still some that we can also explain by the fact that some of the children would come for specific immunization, etc. So it was also a dialogue actually between the people in the field and the analysis team to try to understand all this and to really ensure the quality. And next slide. And then by that, we were able to really see, with all these kind of first steps done, some proxy prevalence of 𝗵𝘂𝗃 for the different partners, unweighted, but also weighted through the different phase, and to present what would be the phase of the 𝗖𝗂𝗁𝗂𝗃 with this kind of this different data for each of the partners. So it's really different data points that we were putting on top, and not like putting all the children at the same time. Next slide. And so with that, we were able actually since last year to calculate unweighted median and weighted means of all the data, and to try to see and to have a look at the chance of the prevalence of the 𝗵𝘂𝗃 and the percentage throughout the year, with the different data points and with the different partners, and to inform actually the situation, and being able to show when the situation deteriorates due to the change of the situation. Next and last slide from our side. So I think what really important in terms of the lesson learned is that this technical support that we had also with the SMART initiative ensures both the data quality, but also the confidence of the partners and the different partners of the cluster. And through this confidence of the partners and the recognition during each of the meeting of their work, it really helps on the implication on the data collection. And we have seen really an increase in the number of partners providing this individual data, even if the context was really difficult. And it's something that is not easy for everyone. We still really try to balance between this data collection and the programs, and really said that for the partners that were not able to do individual data, were not mandatories, it really helped to have the situation, but some of the partners are not able to do, and the main objective of the 𝗵𝘂𝗃 screening is, of course, to detect the children and have them integrated into the programs. We started the integration also the data on the pregnant and breastfeeding women since last October. Despite also lesson learned that despite sharing formats, etc., it's still a huge work on data cleaning. It takes a lot of time on the cluster IAMs to try to have this data. So it's also something that we need also investments in human resource to do this work, to support and to try to continue to work with the partners to increase the data quality. We were able to monitor the situation regularly, and we had enough data for an IPC analysis, even if the quality is not as good as what we could have with a smart survey, but it was very important for the recognition of the sectors within the humanitarian response in Gaza, and for communication on the nutrition situation with sufficient confidence. On the next step that we want to do is to try to add additional information on, for example, whether the children that are screened are beneficiating of some of the programs, so we can better understand and use the data and have some more granularity on the data and the utilization of the data. And we also plan for next week a training on the Palestine team on this data collection, analysis, etc., to be able to have more autonomy, a little bit less dependence of the team of the Smart Initiative that really provide a very tremendous support throughout the year, and also again autonomy for the team. Thank you.
Thank you very much, Corinne. So moving on to the next presentation from Niger with Justine. Justine, over to you, please.
Thank you, Hassan, and good afternoon, everyone. So today I'll be presenting on Niger experience with nationwide MUAC screening. So I'm stepping in for my colleague Gail, who is nutrition specialist with UNICEF Niger, but who is actually on leave. So I've not been really directly involved in the implementation of that MUAC screening, but I'll do my best to share with you the key elements of the experience. And also there is some colleagues from the national level that are here with us, and we'll be happy to help answer the question if you have any specific question. So why first an exhaustive MUAC screening? So Niger traditionally conducted annual nutrition survey, but due to political and financial constraints, no national survey, smart survey have been held since 2022. And also, the most recent data on the nutrition situation reveal a critical situation with, as you can see, high level of stunting, acute malnutrition, and also projection indicating that the population will face severe food insecurity during a lean season, at least in 2024. And so there was really a need for timely and reliable information data on the nutritional status of children to guide the government in its intervention. And National Vaccination Day, and also this is the whole package. There is National Vaccination Day for polio, and they also distribute vitamin A and deworming, and it was identified as an opportunity to also attach an exhaustive screening. Next, please. So really the general objective was to assess the status of children aged 59 months through the measurement of MUAC, and then to use those results also to inform the 𝗖𝗂𝗁 analysis and the 𝗟𝗶𝗁𝗂𝗀𝗃 mechanism. And there was also, on top of estimating the prevalence of acute malnutrition, another objective that was to assess the treatment coverage for acute malnutrition. So really, this was a national coverage with 72 health districts covered, and there is no sampling as it is like all children are screened. It's a door-to-door census. And the data collection tool that was used was 𝗂𝗂𝗀, and the questionnaire were put on a smartphone and shared daily. And a very common variable were collected: sex, age, and months, MUAC in not, of course, in colors, but in millimeters, and treatment status of the children that are identified MAM or SAM. And the data were collected during 4 days. And the survey team was composed of 2 people, 1 enumerator and a measurer. Next, please. So as it can be something that we can replicate in other countries, we thought that it would be interesting to see the different steps to operationalize this opportunity. So this is really how to turn this opportunity of the vaccination campaign into a reality, and what are the different steps it requires. So there is a big step that is really a training cascade, where to operationalize the approach, national trainers, regional staff, and local supervisors were all trained in a phased manner. and practical session, including training on MUAC measurement, but also how to enter the data in the 𝗂𝗂𝗀𝗃 questionnaire, and the distribution, of course, of the product, vitamin A, deworming tablets, and polio vaccine. So this was set up to ensure that all actors from the central level down to field agents were all prepared. So it is to say that it really required like lots of training, and yeah, and also the field agents were selected on two main criteria, so literacy and also if they have a smartphone. And also here to highlight that there was a huge number of teams, because it was more than 20,000 teams composed of two agents that I said before. Next, please. I will not go into the details, but this is just to show that coordination took place at every level. At health center level, the staff ensure really that the supply is available and verify all the data that were entered in the field. At the district level, there is like daily briefing, help identify and solve the field issues. And then the regional team, they synthesized data and communicated with the central level. And at central level, there was really a team that monitor progress and ensure the data quality, at least as they can, and provide guidance to address any issue they can identify, and then they give feedback again to the field. So it's also to show that it requires a lot of coordination and supervision. Next, please. So here you have the results. So first, the data quality. So the quality criteria used were those from the 𝗖𝗂𝗁𝗂 and especially the standard deviation that was the main criteria. And as you can see, unfortunately, among the 72 health districts where the screening happened, only 34 meet the quality criteria. So yeah, this is really something we had to improve. And but as I said before, the data collection lasts only for 4 days, and there was a huge number of teams. So as you can understand, it was quite difficult to supervise and also to check the quality of the data that are coming to the central level. Maybe just a little update on the results. So the prevalence of global acute malnutrition was 8.5%, and varying inside the region, ranging from 2.3% to 18.5%, and the prevalence of some was 2.4%. And regarding the treatment coverage, 48% for the outpatient therapeutic feeding centers, and it was 70% for the outpatient supplementary feeding centers. Next, please. So, as I said before, all those results were used to inform the 𝗖𝗂𝗁𝗂. So, as you can see on the map below, where there is the area that are strike through, is the area where we were able to use the MUAC data. And for the area, so more than half of the area where we cannot use the MUAC data because the quality was not good, they use like historical data on 848 coming from Smart Survey. Next slide, please. So this little table is really to show you that there is like advantages to both approaches. So for example, if we compare the exhaustive screening with a smart survey, the representativeness could be better for an exhaustive screening as it is at district level, while most of the time, smart survey, they're representative at regional level. If we compare the level of proof for IPC classification, however, like exhaustive screening is a medium level of proof, while smart survey high level. Regarding the data analysis, one of the point to use the exhaustive screening is that it was only done by the nutrition direction, so it was straightforward, quick and cheap, while the data analysis for smart survey, they're often do in collaboration between the nutrition direction and the Institute of Statistics. The report was quickly available for the exhaustive screening, And sometimes with smart survey, it could take a bit more time, like some weeks. However, right now we have also the Smart Plus studies starting, so it will reduce also the time for the report to be available. And as you can see, you can compare the cost. The exhaustive screening was a little bit less costly than the Smart survey, but not that much. Regarding the limitation that we've identified, there was the use of multiple and uncoordinated data collection platforms, so different platform actually for the vitamin A data and for those on MUAC. So it was leading to really questionnaire overload. So there is really a need for harmonization and a room for improvement here. There was also insufficient data uploads to the server due to poor internet. And the quality of data, as you've seen, was really poor in some health districts that has to be excluded from the results. And this was really due to weak or inadequate field level supervision. But as we have already stated, so a huge number of team and only 4 days. So, and inconsistent and incomplete data entry as well, due also to a lack of daily plausibility check and delays in timely transmission of screening data in some districts. So while it is a very interesting approach, it still have there is still some room for improvement. Thank you.
Thank you very much, Justine. So moving on to the next presentation from Myanmar. Emily and Joy, please.
Yes, I'm going to present nutritional vulnerability analysis in Myanmar because we conducted a nutrition vulnerability analysis because of the limited access require localized adapted analysis method, and also the standard surveys are not possible because of the insecurity and displacement pose a significant challenge. So the nutrition vulnerability analysis offer practical ethical alternative, and also we need the urgently or the evidence to consider for the nutrition program, especially for the children and PPW. Next slide, please. In the nutrition vulnerability analysis, we apply a step approach, and we was led the national AMIT technical working group and the leadership of nutrition cluster, technical support from UNICEF and WFP headquarters. In the first step, we define objective, scope, and engagement. And also we met and comply the relevance and existing data, including assessment, survey, and report. We leverage routine data and integrate multi-sectoral nutrition question into the ongoing assessment as well. Then, as a step 4, we design and conduct the qualitative data collection, synthesize the interpret data with multi-sectoral partner to build consensus and to ensure that the data triangulation and context analysis. And as a step 6, we validate and conclusion with the partner and finalize the analytical reports. And then we share the result and integrate in decision-making process. And reflect on lesson learned and strengthen the future application. So this and we allow inclusive and context appropriate to ensure, because we consider the barrier data, so by considering the data triangulation approach. Next slide, please. Yes, for the methodological aspect, geographically, we focus on 4 targeted areas across 2 states. Qualitative data, because we use the primary evidence because of the absence or recent quantitative data. So key informant interview was conducted with the lead or the consultant, and also is involved CSO partner, frontline actor, community leader. So about 5 to 10 KNI interview were carried out in each township is conducted in March. And also in addition to this, we also consider the sectoral and thematic assessment, MSNA, reach impact, food security analysis, and other relevant sources. To strengthen the data triangulation, we also consider the programmatic and field observation provided by international local partner working across nutrition, food security, health, and wealth sector. Next slide, please. Yes, for the analytical framework, the NVA, we consider all the key pillars like food security, health, environment, service, access, care practice, and aggregative factor as well. We examine the food security situation by considering the household food security and dietary diversity, and also health environment, the disease prevalence or the targeted area and the health condition as well, and also service asset, the availability and also the functioning or the health services, well services, nutrition services were also considered, and also the other care practices and the other aggregating factor like the complete and displacement and severe distraction are also considered. So these pillars provided a multi-sectoral lens to assess nutrition vulnerability even in the data limited situation. Next slide, please. In the methodological aspect, we use the consent scoring approach. There is co-assignment, the plenary session, involvement of the stakeholder who bring the constituent and operational expertise. And we also focus on interpretation, discussion, and expert judgment. So it's not a numeric threshold. The score is rate 1 to 5, where is the minimum no consent. So it means there's no consent for them. Scoring 1 and 5, critical consent, the urgent intervention are needed. So we consider our methodological aspect by scoring with this 5 consent stage. So I will over to Emily to present for the finding. Over to Emily.
Emily, over to you.
Yes, sorry, I'm having internet access. So looking at the the consent scoring approach, we had different categories with from minimal concern to critical concern. So if you can move on to the next slide, please. Yes, so this is the overview of the finding that we had. And if we look at the drivers that we looked at, so we looked at food consumption, market and food prices, livelihoods, coping strategies, health and maternal child services, disease burden and health challenges, 𝗖𝗂𝗁𝗂𝗃 practices, and finally WASH. And I think again, so we were across 2 states in 4 different townships, but I think it's quite obvious looking at the table here that we were able to shed some light on a very concerning situation in most of the areas, reaching up to a critical level in some parts. You can move on to the next slide. Thank you. So the limitation was clearly conducted under significant operational and access constraints due to the context of Myanmar. So certainly some of the following limitations need to be considered when analyzing the find and interpreting the findings. First, so really the gap in data. There was no anthropometric data collected due to access and logistical barriers. So really, I mean, and I think it's quite interesting for me to see how this is different from the experience of my colleagues in Niger and Gaza. Is for us in Myanmar, the experience, the findings were really based mostly on the key informant interviews, and so it was really mostly qualitative inputs as well as secondary sources. In terms of the coverage constraints, again, a bit different from what I can see from the experience of my colleagues. I think the sample and the coverage was quite limited for the Myanmar experience, mostly due to the fact that we didn't have access to many of the areas. And clearly that means also that the findings may not reflect the condition in some more remote locations that we couldn't implement the NVA in. Finally, again, also in terms of coverage constraints, I think there is clearly an underrepresentation of some of the groups in Myanmar. It was mostly host communities and IDPs, but we don't really have a good representation of displaced population or marginalized population. And again, so one of the limitations maybe in the findings of the NVA for Myanmar that, again, so also due to the fact that this is very limited in terms of quantitative data, but it's mostly a snapshot that we could capture through the key informant interviews at a point of time. Obviously, in a context that is evolving quite quickly with the ongoing conflict and the market disruption and the displacement of population, these findings may be accurate at the time, but they might also be a bit obsolete quite quickly. And finally, also, we collected this data just before the earthquake that happened in Myanmar in April. So although the regions where we collected the data were not directly impacted by the earthquake, obviously also this at national level, this has also a little bit changed the dynamic and the situation and the vulnerabilities. Next slide, please. But regardless, I mean, of the limitation, it was really good that we were able to come with some strong key messages from the analysis. First, really to shed some light on the risk of escalating situation for malnutrition in those regions. We could really see that the acute malnutrition drivers are intensifying with inadequate diets, collapsed services, and deteriorating care environments, threatening the survival of under 5 children and pregnant and lactating women. Also, reflection on the constraints on access to aid for population, which really leaves the system with major service gaps, including life-saving nutrition support. So in both of the, as you could see in the analysis framework, really in both of the zone and all of the townships, we could see that displaced population, more specifically displaced population compared to the host community, face really extreme deprivation, severe food shortages, and harmful coping strategies. Additionally, there is clearly a disruption of access to health systems and health services. There is really like a clear threat of measles outbreaks with unsafe conditions and little or no capacity for acute malnutrition detection, treatment, or prevention. On the more positive side of those findings, though, there is still a window for action, as there is still partial access and system functionality in the zone that we conducted the analysis in. Next, please. So again, I think in terms of really the good outcomes for the NVA is to be able to translate these findings into some recommendation that, you know, can both be used for advocacy, but are also very operational for partners. So the main recommendation really from the findings were to rapidly restore and expand the nutrition services, including early detection and treatment of acute malnutrition, using a mix of fixed and mobile services, and really to scale up the community screening, the referrals, and the delivery of RUTF, which is obviously a big challenge in terms of malnutrition treatment in Myanmar. There is clearly a need also to reinforce and monitor nutrition surveillance systems. In general, to scale up emergency food assistance and cash assistance. In terms of access to health services, to rebuild essential health and WASH services, especially to try to minimize the risk of outbreaks, which is very high at the moment, especially in the aftershock of the earthquake, even more probably than at the time we collected the data. That interventions really need to be community-led response, implicating local health workers and volunteers, including some training, but also to provide them with supplies to deliver context-adapted services. And again, to prioritize, so to avoid like further deterioration of the situation and the deepening of the crisis, to prioritize targeted prevention in areas where conditions are deteriorating quite quickly and critically. Next, please. So the lesson learned for us, it's really to be able to, in this almost complete absence of quantitative data, to be able to have a qualitative method that is quite structured, and which is very adjusted to the constraints we had about access and the overall context. So for me, I really appreciated the flexibility of the methodology, because again, we had a lot of constraints, and yet we were able to come up with a methodology that was context appropriated. And I also think that, you know, it was really important to have this collaborative approach for the analysis part. So having, you know, in the panel for the analysis, we organized several sessions, some in Burmese, some in English, just to make sure that we could really include stakeholders at different levels, some of them really grounded in the operations at community level, but also, of course, international experts and advisors. And I will finish here because I think, Hassan, you're cutting me short.
Thank you very much, Emily, for that presentation. So we'll have some time to go into questions. Alex, if you're there, please go ahead.
Yeah, thanks a lot, Hassan. So there are a lot of questions. I'm not sure we'll be able to answer all, but we could then send a document with the question answers. I'm going to start with one which is right on point with the current discussions on the adaptations. As someone asked that there was a discussion during the Rome Nutrition Week that focused on localization and covered MUAC screening activities. So while family MUAC is an activity that has been ongoing for a couple of years, has this tool been considered as part of the third process for supported limited access context? And I'm assuming meaning used or considered to be used for surveillance, or regular screening. I don't know if who wants to take it, maybe Victoria or...
Yeah, maybe I can take a shot at trying to respond. Yes, so part of the guidance is really to maximize and optimize the different types of data that you're collecting. Family MUAC is definitely an important sort of adaptation that could be useful for context where access is a challenge. I think what is important to consider also is the quality of the data to meet the minimum evidence requirements for purposes of analysis. So processes like IPC have some sort of evidence requirements that are needed. And I think we are not yet there with family MUAC, but it's definitely an area that needs to be explored and, you know, work on how to improve the quality of those measurements for the purposes of analysis. At the moment, I think they work very well for screening purposes and referral. I think there's a bit of work that needs to be done to get us there to use it for purposes of analysis, but definitely an important option to consider.
Thanks a lot, Hassan. There is a very concrete questions as well, so I think it's a bit easier on that. So concrete. I don't think we have a smart specialist, but Hassan, you are. So again, it might be you if no other members of the panel. So there is a question on if there is a repertoire or centralized database of nutrition survey form and specified XLS forms that goes beyond basic data capture that exist. Specifically, are there resources that integrate functionalities for supervision, quality assurance, and automatic VET score calculation directly within the survey templates? So I think...
Yes, and the short answer to that is yes, this now exists. If you visit the Global Smart website, you will see that there's a Smart Plus tool that does exactly what you're asking. So there is these resources and are now available.
Maybe we can put it in the chat.
Yeah, we can put that in the chat.
Wonderful. Somebody is asking, again, maybe for the chat or later, can we have the reference material for the concern scoring approach? So just a reminder if we could maybe put that in the chat or send it later. There is also, that's more a question for the GNC in general. What are the types, sorry, I'm translating directly. What are the type of technical support, training, supervisions, tools that the GNC can give to guarantee the quality and the robustness of collected data, mostly for local partners and government?
I think Miriam is there, and I don't know if you want to respond to that, Miriam. But there's a link that was shared on the chat to get more information on that.
Great. So we have time for a little bit more questions. So maybe a question for Myanmar. Why was the NVA approach selected over other methods in this context of Myanmar, and what were its main strengths?
So if I can go ahead,
Yeah.
the NVA was really selected because we have it is not possible at the moment to collect any data or to conduct any proper nutrition surveys. For example, in some of the areas where we conducted the NVA, the last SMART survey was done in 2015. So obviously it is quite outdated with the evolution of the context during the last years. And really the strengths, as I said, for me, it's really the fact that it was very flexible in the way we developed the methodology, like very specifically for the context and taking into consideration all the constraints that we had. Some of them was communication with some of the regions, some of them was access, some of them. So as I think for me, that's really the strength of the methodology that I've discovered. It's the flexibility and the capacity to adjust it really to the context.
Thanks a lot. Another question, this time before the first case study on Gaza and the constrained environments. How did you balance the need for frequent data collection with the burden on the partners and the frontline staff in such a highly insecure setting? Might be muted if you're trying to answer.
Maybe one day, or Perrine, if you're with us.
Yeah, I was wondering if one day what. Yeah, please go ahead one day.
Yeah, thanks, Perrine, and thanks, colleagues, and apologies, I couldn't join on time. Yeah, I mean, the situation is tough. It's very difficult to collect data, and our aim was to do a standard nutrition assessment. That's a SMART survey. We tried a number of times, even we conducted a training, but that couldn't happen. But for the purpose of programming, collecting the data, screening children and identifying cases as early as possible is mandatory, and that's what our partners are doing. And we do have adequate number of partners who are reaching children in areas which are accessible. I mean, as you know, some of the areas in Gaza are no-go zone, and there are no population there, but in areas which can be accessed, the screening is conducted for a program purpose, and that's how we converted it into using for also assessment and monitoring, ensuring the quality is maintained and providing repeated trainings so that quality of the measurement improved. I don't know if that satisfies. Over.
Thanks a lot for this. As I'm looking at the time, I'm going to give you back the floor to close.
Thank you very much, Alex. And colleagues, for those questions that maybe you have, please do not hesitate to still reach out to us. We would be more than happy to provide you with a detailed sort of response. Please note that the guidance is now available on the GNC website. You can access the actual guidance there. Within the guidance, there's a link that you can provide us feedback on how the guidance can be improved. As I said earlier, this is a live document, so we most welcome the feedback from the field, so we can improve and make these processes and these adaptations more applicable to your respective context. Looking for support in nutrition in emergencies, you can access you can make this request through the GNC portal, and this is a wide range of requests that you can make. Please see the link on the last slide. But here on the screen now you have the site where you can access the guidance. And with that, we want to thank you all for your time. Thank you to all the presenters. Thank you to all the interpreters who've been sort of kindly interpreting in the different languages. And we wish you all the best in the rest of your day. And please do not hesitate to reach us if you have any questions or any requests for support. Thank you.
Thank you very much, Hassan, and all the panelists.
Thank you.
Thank you. Bye.